Well, hello, everyone, and welcome. So there's already so much excitement to jump into the information, and so I'm really excited about that, and want to appreciate the opportunity to welcome you all to this Department of Health and Human Services Office of Minority Health Sickle Cell Disease webinar. We are so very pleased to sponsor this webinar in the month of September, which is National Sickle Cell Awareness Month. Again, my name is Radmal Felicia Collins, and it really is my honor to serve as the Deputy Assistant Secretary for Minority Health within the Department of Health and Human Services and the Director of the Office of Minority Health within the Office of the Secretary. Now, for those who may not be familiar with our office, the Office of Minority Health, or OMH, is focused on helping to reduce differences in health outcomes or health disparities for racial and ethnic minority and American Indian and Alaska Native communities. OMH does not provide direct clinical services or direct social services. Instead, you can think of us as a research and development shop for policy and program development. We use our functions related to analyzing data, convening partners, disseminating information, and conducting policy and program demonstration grants to assess the impact of policies, programs, and practices on health disparities for racial and ethnic minority and tribal populations. Now, once we identify successful policies, programs, or practices that address health disparities, we then work to support their sustainability and spread, to include seeking other parts of the Department of Health and Human Services or other partners to support longer-term project implementation. Consistent with this programmatic framework, OMH seeks to share and spread successful policies, programs, and practices. And thus, today's webinar will highlight the work of an OMH award recipient that has demonstrated the effectiveness of interventions related to the treatment of children with sickle cell disease. Sickle cell disease, or SCD, is the most common inherited blood disorder in the United States, affecting more than 100,000 Americans. The disease impacts 1 in 365 births in the Black and African American community, and 1 in 16,300 births in the Hispanic or Latino community. It is estimated that 1 in 14 Black or African American babies are born with sickle cell trait. In addition, about 40% of individuals with sickle cell disease in the United States are children and adolescents. Now, unfortunately, research and other resources supporting those with sickle cell disease pale in comparison to that for others that have other genetic disorders. So, in September of 2020, the Office of Minority Health launched its demonstration initiative to increase hydroxyurea prescribing for children with sickle cell disease. The goal of the initiative was to demonstrate the feasibility and effectiveness of providing financial incentives to providers to improve the quality of life of children with sickle cell disease through increased prescription rates of hydroxyurea. Now, for those of you who may not be familiar with hydroxyurea, it is a medication that has been proven to be successful in reducing rates of hospitalization, pain encounters, and emergency department visits for children diagnosed with sickle cell disease. OMH awarded $4.25 million to New York City Health and Hospitals for this demonstration project. And again, I'm so delighted that the New York City Health and Hospitals awardee team is here to share their work with us in honor of Sickle Cell Awareness Month. They will provide an overview of their grant project, including their approach to the demonstration work, highlights of notable outcomes, and a discussion of their lessons learned. Again, thank you so much, New York City Health and Hospital team, for joining us, and thank you to everyone who has joined us for today's webinar. With that, I will turn it over to our moderator for today's webinar, Tish Hall, one of our team leads within the Office of Minority Health. Tish?
Thank you so much. And again, welcome today to the webinar on improving sickle cell disease through the efforts of New York City Health and Hospitals. And we're delighted to have you with us. But before we get started, we want to begin by extending a special thank you to Rear Admiral Collins for her insightful opening remarks and for setting the stage for today's important discussion. I'd also like to acknowledge Captain David Wong, for the work that he has done and continues to do for sickle cell awareness and treatment, and for those living with sickle cell. Again, my name is Tish Hall. I'm a public health advisor and one of the team leads in the OMH Division of Program Operations. I will be your moderator today. Because in interest of time, and we want to make sure that we get into the presentation, I want to start by saying I'm going to just offer the housekeeping tips because you're going to get all the great information coming forward from our presenters. So a few housekeeping tips for running the session today so that we will run smoothly. This session is in listen-only mode with all participants muted. If you experience any technical difficulties, please use the chat and we'll assist you as promptly as possible. Please also make sure that your name is properly displayed in the Zoom caption screen. No Zoom user or anonymous user should be noted. Second of all, this webinar is being recorded and will be posted on the HHS OMH YouTube page. We'll provide a link to this recording to all who have registered, and so you can go back and watch it later and to share with other people who could not participate today. Last but not least, we will have a portion of question and answer that will be at the end following all presentations. We encourage you to submit your questions via the chat feature throughout the webinar. We will also address both live questions that have been sent through the chat, as well as those that were submitted during registration. We thank you for sending those. Please also include your name, your email address with your questions in the chat so that in the case that we are not able to get to them, we can answer those at a later date and time. Now, let me take a moment to introduce our esteemed speakers and provide a, well, not so quick overview, but I'm not going to do the overview. I'll allow them to do that. From New York City Health and Hospitals, we have Dr. Jean-Bernard Pollard, MD, MBA. He is the project director and co-principal investigator. We have Dr. Kenneth Rivlin, MD, PhD. He is the co-principal investigator. We have Dr. Marcy Stein Albert, and she is also a co-principal investigator. We have Bruce Bernstein. He is also a part of the team as the grants and contracts director. We have Candace Alfonso, who is the grants coordinator. We have Lindsay Kogan, who is the Deputy Director of the Office of Health Equity and Services and Analytics, and she is a part of the evaluation team that is with the New York State Department of Health and Health Research. So without further ado, I will turn this over to Dr. Pollard so that he can begin the presentation.
Thank you, Tish, and thank you, Admiral Collins and staff at OMH. Our story started with application for the grant. As a recipient of the HHS OMH demonstration grant to increase hydroxyurea use in children, New York City Health and Hospital embarked on a health system journey to improve the quality of care provided to our patients with sickle cell disease. We present an integrated suite of tools and collaborative actions designed to enhance the quality of sickle cell care. Next. Our agenda today is to define the problem, tell you a little bit about our settings, our approach to the project, the development of resources and tools necessary to accomplish it, the evaluation and outcomes, as well as the challenges and lessons learned. And finally, how we're building on the work that was done for sustainability. Next slide, Dr. Rivlin.
Thank you. I thought we'd start with just a very quick overview of what sickle cell disease is. As you heard, it's an autosomal recessive genetic disease that's characterized by the intravascular breakdown of red blood cells that creates anemia, and from the patient's perspective, it causes unpredictable episodes of severe pain. Sickle cell disease was the first molecular disease. It was the first disease we knew the exact problem at the level of the DNA. A mutation occurred where a T replaced an A, which caused the protein in the hemoglobin molecule at positions, amino acid at the hemoglobin molecule at position 6 to go from glutamic acid to valine. This caused the hemoglobin molecule, when it let go of oxygen, to have two sticky components. And when you have two sticky ends of a molecule, they stick together. And in the next picture over, you see an electron micrograph of a red blood cell with the actual crystals of hemoglobin that cause the red blood cell to break apart. And those crystals of hemoglobin cause the red blood cells to take the characteristic sickle shape. Next slide. As you heard from Dr. Collins, sickle cell disease affects about 100,000 individuals in the United States. About 90% are Black Americans, about 10% are Hispanic Americans. And there's a small proportion of individuals from the Mediterranean regions, India, and Middle East. It occurs in about 1 every 655 African births, and it occurs worldwide in about 20 million individuals. It actually, sickle cell trait, just carrying one of the genes, is actually a superpower. It prevents malaria. So anywhere that malaria falciparents is, you're going to see sickle cell disease. Next slide. So what does it cause? The hemoglobin polymerization causes the sickling of the red blood cells. It causes the breakdown of red blood cells. It causes damage to the blood vessels. It causes blockage of the blood vessels, and it causes a sterile inflammation within the blood vessels. So we're dealing with a disease that in medical jargon would be called vasculopathy, but it's a disease of vascular injury. Next slide. So what does it do clinically? Well, it's a disease of blood vessels. So anywhere blood flows, you can have a complication. So if blockage of blood vessels occur in the brain, it causes stroke. Blockage of blood vessels in the lungs can cause something called acute chest syndrome. In the bone marrow, it causes pain. In the skin, it can skin ulcers. In the spleen, it can decrease the function of this part of the immune system and allow overwhelming bacterial infections. It also causes early mortality. The median life expectancy for SS disease is in the 50s. Next slide. So what's it like to live with sickle cell disease? I think for most general people in the population, we hear about cancer, we hear about people getting chemotherapy. Well, living with sickle cell disease has a worse quality of life than getting active chemotherapy. So that's what this slide is showing. Next slide. This is a famous picture called Beyond 10 by an artist, Hertz Nazare. This is a painting he did after a pain crisis, and it exemplifies the face of sickle cell disease that our patients see. Sickle cell pain is worse than the pain of pregnancy. When you're pregnant, that contraction will go away. It's worse than the pain of breaking a hip. That pain, you'll find a position where it's a little bit less. That pain is just gnawing on patients. Next slide. This is also our reality for sickle cell disease. If you look at the graph on the left, you see the dotted line. There's been a significant decrease in deaths for young children with sickle cell disease. The problem is we're not doing as well for adults with sickle cell disease. The graph on the right is looking at different times and the ages of death. If you look at the black line, you see a hump very early in life, and that was in the 1970s. We used to lose about 1 in 3 children from sickle cell disease. Now it's rare for us to lose a child with sickle cell disease. The line in red is where we are today, and it shows that we're still not doing as well as we could be doing. And it's showing that we have a high death rate in the adult years, and that's something that we need to address. Next slide. So the question is why? Next slide. And part of the reason is summarized in this quote. Sickle cell disease is a microcosm of how issues of race, ethnicity, and identity come into conflict with issues of healthcare. As a practitioner in a city, we see disparities of healthcare all the time. I don't think there's a better example of systemic racism than sickle cell disease. Next slide. This disease has been persistent. The problem with this disease has been persistent over time. The article on the left was called Sickle Cell Anemia, High Prevalence and Low Priority, was in the 1970s. The paper on the right is addressing sickle cell disease that was sponsored by OMH. And it also highlights the disparities in sickle cell disease. Sickle cell disease is a disease of high burden. Patients have a poor patient experience. They have poor quality of care. They have high per capita cost. They are a low priority because of affecting predominantly minorities. They are many are people of low socioeconomic status. And the numbers of patients with sickle cell disease are low. It's a rare disease. Next slide. So we're indebted to OMH for taking on sickle cell disease and working with the National Academy of Science, Engineering, and Medicine to create a blueprint for how we can address sickle cell disease. And this slide, which will be distributed to people, has the blueprint and the stakeholder meetings that went on. Next slide. Our tasks for this grant was to increase the use of hydroxyurea. Hydroxyurea is an amazing disease-modifying drug. It decreases the episodes of pain. It decreases many of the complications. It decreases stroke risk. It improves the quality of life. It increases life expectancy. But this medication is used in less than 50% of patients eligible. Our task was to help support patients and families in making the decision to use this disease-modifying medication, overcoming the barriers. Next slide.
Okay.
Ernie?
Our setting in the New York City Health and Hospital. As the largest public hospital system in the nation, it serves all, regardless of ability to pay. It serves a diverse population of 1.2 million New Yorkers, predominantly low income. 80% of our patients are Medicaid and 5% of the patients are uninsured. By the numbers, we have 11 acute care hospitals, 28 federally qualified health centers for Gotham Health, over 70 ambulatory care sites. Annually, we see 4 million ambulatory care visits, 1 million emergency department visits, 160,000 discharges and 15,000 births in the city. Next slide, please. As far as sickle cell disease is concerned, we at H&H is one of the largest providers of sickle cell care in the United States. 2,500 sickle cell patients touch our system in a year. We follow 1,200 sickle cell disease patients in our clinics and our settings. 500 of those are in the pediatric age range from 0 to 21 years of age. New York City Health and Hospital has 6 New York State designated hemoglobinopathy centers for pediatrics and newborn services. The Bronx, the Lincoln Hospital and Jacobi Hospital. In Manhattan, Harlan Hospital and Metropolitan Hospital. In Queens, Elmhurst Hospital, and in Brooklyn, Kings County Hospital. Next slide. I think that HHS OMH demonstration grant goal for each of the 3 providers type that encounters patients with sickle cell, whether it's primary care, pediatric hematology, or PEDS emergency department, we work to develop performance measures for hydroxyurea prescribing, develop and implement incentive payment plans, and evaluate the effectiveness of financial incentives. Next. We established early on some guiding principles, recognizing and addressing sickle cell disease healthcare inequities as unacceptable. It's a condition that can be addressed, prioritizing high-quality activities specific to sickle cell disease across the system. Aligning sickle cell disease management with the 2020 National Academies of Science, Engineering, and Medicine report addressing sickle cell disease, ensuring a comprehensive, systematic, patient-centered approach to care. Create a shared mental model so that all clinical staff, whether it's primary care, pediatric hematologists, and pediatric emergency departments physician in contact with a family can support hydroxyurea use and support the clinician with the necessary tools, resources, and incentive to optimally manage children and adolescents on hydroxyurea. Collaborate with our sickle cell community partners in supporting hydroxyurea use. Next.
So our next steps were program implementation. We first established teams to be able to support the work ahead. Of course, there was the leadership team, the core grant team that you've already been introduced to, and we're the folks that are presenting today. We had already a clinical care committee of sorts through the Project ECHO model that Dr. Rivlin led for sickle cell disease across our enterprise. We built on that and expanded that into a clinical care committee. We established also a payment committee where we resourced from our managed care organizations, our finance folks at H&H, but also at the New York State Department of Health. And then we engaged an evaluation committee, the lead of whom will be presenting later in this discussion. We established 4 clear objectives. Our first was, again, to create a foundation enhancing clinician knowledge of best practices and our shared mental model, as we discussed. Building a guiding infrastructure really meant how do we create the tools and support needed for our physicians to achieve those best practices. And for those of you who are clinicians, you know that a lot of that is dependent on a very robust electronic health record, which actually helps clinicians provide best practices and document well rather than creates a barrier. Our third objective was integrating community support. We already had some sickle cell disease community-based organizations in the New York area, but we built on those relationships through this grant. And the last, which again is still something in the works, and that was developing a sustainable financial model, whatever that will look like, to be able to support clinical teams and clinicians to provide this care in the manner that we've already established nationally as best practices, and that what we've learned through our progress on this grant. Next slide. So that first objective, enhancing clinician knowledge to achieve best practices, and that shared mental model started with us creating a learning module. Dr. Rivlin and myself created this module. It's about an hour long. We put it up on our online electronic educational platform at Health and Hospitals. We pushed it out to all of our pediatric departments, and we offered CME, and it was free. So that was our first step, and it was also a prerequisite to be enrolled in the incentive plan. Next slide, please. So our second objective, what I already had mentioned, was building that guiding infrastructure. And what this entailed was building out a sickle cell disease registry in our electronic health record, which happens to be EPIC, and a sickle cell navigator in EPIC, which really, again, entails, and I'll go into a little more detail, a very strong and simple but elegant way to both document and read and learn data on our patients so that we are the most up to date in treating those patients. Next. So that first component, which was the registry, there was already in the sort of out-of-the-box version of our electronic health record, a very stripped down disease registry for sickle cell disease. But we spent probably about 6 months to a year in building out this registry so that it collected all of the health metrics that were connected to best practices and would allow us to then, on a systems level, at a facility level, at a department level, and even at a provider level, monitor those quality metrics and how well we were doing. Next. So the navigator really, in EPIC, the documentation navigator really has 4 sections. One is the disease modifying therapy. And again, the main issue here, although there are other disease modifying therapies, where we wanted to be able to query our patients as well as introduce, if patients were not already on hydroxyurea, hydroxyurea use at all 3 settings: in the emergency department, in pediatric primary care, and obviously with the pediatric hematologist. And so we built, again, a disease modifying therapy component of a smart form. We also collected our sickle cell history, key clinical metrics of a sickle cell history. In this smart form. Any complications are also documented in this smart form, and the health maintenance screening tests and evaluations that we know are key to promoting health are collected in here. And so these are discrete data points that are pulled from our electronic health record, but they are also pulled from the Regional Health Information Organization in our community in the New York area, so that if our patients go elsewhere, we are also collecting these key metrics into their health record, and we can be kept up to date. Next slide, please. So the next component of this navigator is the individual pain action plan, and Dr. Rivlin speaks about this very frequently. So, you know, we have a lot of pain management plans that are very generic, but it is really important to individualize these pain plans. The patients, the families, and the primary care provider and hematologists really do know better in knowing the patient and the family what works best for that patient. And so The goal was to be able to have these individualized pain plans completed in the setting of the primary care provider or the hematologist with the family, again, as a shared mental model. And much like the asthma action plans that clinicians are familiar with, we characterized a plan here in the same way: mild pain, moderate pain, and severe pain, and how we want to intervene and treat those different degrees of pain, again, for the family to be able to know how to be empowered to be proactive at home, but also, as you'll see on the next slide, how the emergency department can then manage the patient, first steps when the patient presents with severe pain to the emergency department. So the action plan can be reviewed and updated at each visit by, again, the primary care provider or the hematologist. Every time it's reviewed and updated, it prints out from our electronic record and is given to the family, also obviously updates in the system. And the severe pain management plan is viewable by the emergency department. So when that patient comes in, they're familiar with what first steps they should take to manage the severe pain. And just a little footnote here, this individualized pain plan also tries to humanize our patients in the best way we possibly can. So we have a preferred patient profile where we tell a little bit about the patient as an individual, not just as a patient. So in this case, 14-year-old who loves soccer and excels in math, so that that treating clinician, and even in the emergency department who doesn't know that child, that family, can approach the patient in a different manner and know a little bit about that patient. Next slide. So the next component is, and again, some clinicians may be familiar with transition tools for adolescent patients to transition from adolescent or pediatric healthcare to adult care. A lot of times patients with chronic disease and even patients who are healthy get lost in the mix when they transition to adult care. It's a different environment of care. They don't feel as sort of nurtured the way they do in a pediatric environment. And it's really, really important to make sure that that transition happens and the patient and the family are ready for that transition. So this transition tool is a dynamic one, and it really seeks to establish that the patient and the family, but in particular the patient, has advances with as they get older with understanding and proficiency and confidence in their care. And each time the questions are asked, beginning at age 12, as all the way on up to, in some cases, 21, the colors on the transition tool change. And when most of them are green, we know that that patient is ready to transition to adult care. Next slide. So we had a whole bunch of other tools. Again, for those of you who are familiar with Epic, there are these smart links and texts and phrases and smart sets. We built those also. That's a little less innovative. A lot of folks build these things, but we also added that to the suite of tools for our clinicians. Next. And then lastly, we wanted to be able to provide patients with sort of a very quick but informative one-pager every time they come into a clinical setting, be it the ED or, again, primary care or hematology. If they're not already taking hydroxyurea, there's an automatic printout of a one-page patient education material, which, again, includes some very straightforward and clear information about how hydroxyurea works. And at the bottom, there's a QR code for a web video. Next slide, you'll see here, which actually has real Health and Hospitals patients with sickle cell disease who are taking hydroxyurea, and they sort of give testimonials about their journey having taken the medication and how it's transformed their lives. So this is what we give to patients who are thinking about it, but haven't made, a decision yet about starting hydroxyurea. Next. So along with our engagement with the community-based organizations, a very key component to supporting our patients and families, and in fact, supporting our clinicians, is our including community health workers in the mix. So we have a community health worker that's specifically dedicated to supporting our patients with sickle cell disease. And the clinicians through the electronic record can make that referral. And again, it's tracked. Our entire corporation, anybody can refer to the community health worker. Community health workers, as you will hear, have a variety of roles in the care team, from navigating the healthcare system to connecting our patients with community-based organizations. Next. And that's Candace.
Candice.
Thank you. So for this project, we were able to form partnership agreements with our local sickle cell disease community-based organizations. Our main reason for partnering with them is because we know that community-based organizations are the hearts of the community, especially for the sickle cell disease community. The CBOs were essential in providing resources, workshops, and programming to their community members. And they also educated and advocated on behalf of the sickle cell community. We were able to partner with the following community-based organizations: Sickle Cell Awareness Foundation Corporation International, Sickle Cell Thalassemia Patient Network, and Candace Sickle Cell Fund. They aided in a lot of resources for patients during this time of the project, especially for patients that needed transportation to their doctor's appointments, and also providing meals for patients who were hospitalized or in emergency department for an extended period of time. They provided meals to them as well as to their families once the patients were released and they were unable to essentially take care of themselves as far as making sure that they get the nutrients that they needed after they left the hospital facility. Next slide. We also partnered with the New York Blood Center. This partnership was essential because sickle cell patients receive blood transfusions for many reasons. During crisis, they might need a blood transfusion for specific procedures. They may need it as well as traveling and other needs. Out of 8 million New Yorkers, only 2% donate annually. And since the pandemic, the number has dropped, making it difficult for the New York Blood Center to keep up with the demand. So here at H&H, for the past 3 years with our partnership for New York Blood Center, we yielded 445 donations, which is equivalent to impacting 1,335 individuals. And one of our highlights that we would like to mention is that we were able to do a blood drive as well as a meet and greet between a sickle cell patient and a donor in 2023. That was very eventful and very impactful to the lives of sickle cell patients. Next slide, I'll hand it to Bruce.
You're on mute, Bruce.
Thank you, Bernie. So I led the development of the financial incentive program. That was a key part of the grant, or a stated goal of the grant, was providing for financial incentives to physicians for treating sickle cell in the correct way. And unfortunately, it wasn't based on the funding announcement. It was only available to physicians. We had to develop sort of an incentive, and we were measuring the results of these financial incentives. Just to review, we had 3 separate physician types: primary care pediatricians, peds hematologists, and emergency doctors, peds emergency doctors who treated sickle cell. In order to participate, they had to complete the education module. Once they completed the education module, they were eligible for the financial incentives. I'm not going to go through the formula now, but if I'll go through the basics of it, I'm not going to get into the weeds on it. But if anybody's interested, we will send more information on that. But it was based on the amount of money they received each quarter was based on both quantity and quality. The quantity was the number of patients they treated or that their practice treated. Quality was they had certain quality metrics that they had to hit, certain things they had to do. I'll give a brief overview of that. And they if they, for example, if they hit 80% of those quality metrics on average, then they would get 80% of their eligible quantity payment. If they hit 100%, they would get 100% of their eligible quantity payment. So just to give a very brief idea of what the quality metrics look like, I'll run through them for the peds hematologists. The provider asked, number one, the provider would ask the question to the eligible patients, are you currently taking hydroxyurea? If the answer was number two, if they were not, the provider would discuss and reinforce the merits of HU. If they were not, that provider would further provide HU patient education materials in appropriate languages to the patients and their family. If the answer was if the answer was no, they would initiate the HU prescription and notify the primary care physician. If they were taking HU, the provider would monitor the metrics, monitor quality of life, monitor other process measures, and finally, for the patients and families not currently connected, they would connect the family with community health workers for decision support. Next slide. I think that's
Lindsay?
yeah.
Lindsay?
Great. Thank you, Bruce. Yep, I'm here. Good afternoon, everyone. My name is Lindsay Kogan, and I'm here representing the team that has been helping to evaluate this project. So I'm going to start off today just with a very brief overview of what we set out to accomplish. When we were looking at the success of this initiative, we wanted to focus on a balance of both short-term and long-term outcomes. One objective of this project was to enhance clinician knowledge around sickle cell disease. So the first thing we wanted to do was to really look at the baseline knowledge as well as attitudes around sickle cell disease in the physician population in this health system. We were able to assess this in both a pre and post-intervention survey, and I'll share those results with you today. The primary outcome around this project was whether there was an increase in hydroxyurea prescribing. We were able to track and monitor this within the electronic medical record registry system, but we also took it one step further. So in addition to, as Bruce just described, some of those quality metrics that were driving that financial incentive, we also wanted to look at more longer-term outcomes. Because of our relationship with the New York State Medicaid program here at the New York State Department of Health, we were also able to match the patient data provided to us by HMH to the Medicaid system and look at more indirect outcomes, such as not only whether a prescription was given to the patient, but whether they actually filled that prescription. Additionally, whether they adhered to the medication. And also we were very interested in acute care visits, such as emergency department and inpatient stays. Next slide. On this slide, it just is a brief snapshot. It was in January 2022 that the Sickle Cell Disease Educational Program was made available to eligible providers. Providers were able to opt into the intervention by completing this educational module, and the associated documentation and outreach across all sites resulted in over 90 providers participating in the program areas across the 9 sites. Next slide. So as I mentioned, one of those main drivers of this project was really to increase clinician knowledge around hydroxyurea. What you'll see on this slide are the results from both our pre-intervention survey and our post-intervention survey. Our first hypothesis was whether if providers were more likely to appropriately treat pediatric patients with hydroxyurea when they had the knowledge on how to better understand and manage that patient population. So in the summer of 2021, our team launched a pre-implementation survey to better understand provider knowledge and attitudes. You'll see that represented in the blue bar. And then in the summer of 2024, we launched a post-implementation survey to understand where providers stood at the culmination of our project here. We wanted to know whether there was any difference. And what we're happy to report is you do see in quite a lot of these metrics, you can see there is a dramatic increase. So for example, if you're reading, I have a baseline knowledge and comfort around hydroxyurea, you'll see that the proportion of providers that answered strongly agree was only 12%, and that pre-intervention survey was well over 40, right around 41% in the post-intervention survey. So you'll see similar patterns across different types of questions. And these are the questions that we really knew based on our background knowledge around hydroxyurea and prescribing patterns, as well as what we wanted to know more about to help sort of drive the project implementation team and allow that feedback to them on sort of where some of those key areas were that they might want to hone in on a little bit more. And these focused around sort of concerns about risks, whether it's within their role to recommend hydroxyurea, how to identify adverse patient reactions, and their confidence in the ability to counsel family members as well as patients. On the next slide, I'll show just a couple of additional questions that we looked at. Again, several factors emerged as influences in the pre-intervention survey on providers' attitudes about hydroxyurea, such as the confidence and access to the pediatric team, time allocation during a visit, and things like technical supports, whether they had access to what they would need in order to provide patients with the information that they would need in order to feel confident, either referring or prescribing patients hydroxyurea. We were encouraged to find again in these types of questions, we found more providers agreed with, or strongly agreed or agreed with, that they had access to things like the sickle cell pediatric team. They again showed that there was adequate time and that they had additional resources. And this really was exciting and lended sort of that further evidence that one of those guiding principles of the project was to support clinicians with the necessary tools, resources, and incentives to optimally manage these children. We feel like this demonstrates to some extent that objective was met. So on the next slide, what we show you here is we're going to jump from sort of provider attitudes and knowledge to now documented evidence that then that next step was taken. And this is demonstrated. This slide shows the proportion of hydroxyurea prescriptions by year and quarter. So these are patients that are seen by either an incentive provider, if the gold bar represents an incentive provider and the blue bar represents a provider that is not participating in the incentive. These are patients that were seen at least once, and they either had evidence of a hydroxyurea prescription or they were prescribed at the time of that visit. When we look at our main outcome, it's really important to not just look at the intervention group. We want to also examine the group of providers that are not involved in the intervention. You can see a pretty dramatic increase in that gold bar. Again, these were the metrics that were directly tied to that financial incentive. So we expected a pretty large jump here. But we also see a little bit of an increase in the providers that were not participating in the incentive. Not as dramatic, but again, we often will look at both to better understand where we're seeing a lot of the change. On the next slide, we wanted to look at not only those metrics that were directly tied to the financial incentive, but we wanted to take it one step further, right? Because there's a difference between being handed a prescription and actually taking that next step to go and fill that prescription. And what we see here is that we not only saw increases among those providers actually prescribing the patients, but we were excited to see that it did translate into those patients actually filling a prescription during both years of the incentive in 2022 and 2023. And again, the incentive providers are the gold bar, and the providers that are not in the incentive is the blue bar. Our baseline period that we compare everything to is the last 6 months of 2019. On the next slide, what you'll see, and again, this is among the subset of the population, Medicaid population, because we had access to the prescription data for only the subset of that population. But as you heard earlier in the presentation, the over 70% of this population in the H&H system is either on Medicaid or Medicare. So although it's a subset, we do feel it's a substantial reflection of the overall population. And so another measure to look at in our sort of cascade of care here is not only those who had at least one prescription, but now we want to go on to see those that not only filled that prescription, but then stayed on it for a period of time. So that gets into more medication adherence, because you don't want to just take this medication once and stop. Although we do know that there could be side effects and some patients may not be able to be on it all the time. The idea is to get a patient on the regular regimen, and that is where the long-term benefits can be seen. So this view shows that not only did we see an increase in those who had at least one fill, we also saw an increase in those who maintained and stayed on that prescription for longer than 80% of the days covered. It's a pretty standard metric when we look at medication adherence. On the next slide, we get a little bit into healthcare utilization. So what this slide shows you is the percent of patients with at least one emergency department visit. And as mentioned by our colleague, it's ideal if we can get a patient on hydroxyurea, if they're getting the care they need, if they have an action plan in place, we should see fewer acute care visits like ED or inpatient. So when we took a look at the data, it was exciting to see not only an increase in the usage of hydroxyurea, but some of these longer term outcomes started to hit. And we figured we would see it first in emergency department utilization before we saw it in inpatient, and that proved to be true. When we're looking at emergency department use, lower is better. So this decrease that you see in the 2022 and 2023 periods are the lower rates here in the gold bars, as opposed to the blue bars, is exactly what we wanted to see. So what we're showing here is the patients who were seen by the intervention group had lower rates of ED visits. On the next slide, you can see that this decrease in visits also corresponded with lower costs when compared to those not participating in the intervention. Again, preliminary, not adjusted for differences in patient populations, but still encouraging nonetheless. On the next slide, we get into a little bit of a more of sort of that next level, right? So emergency department, a little bit more frequent than an inpatient utilization. Now we're getting into a little bit more serious outcomes. And what we saw here is, again, this is the percent of patients who with at least one inpatient stay during the year. What we saw here was a little bit of a different story. We did not see a decrease in the percentage of patients with at least one inpatient stay. Again, we have to really dig in and understand to the full extent the differences in these populations. We want to make sure that we're comparing, not comparing a population who has more complex conditions to those who don't. We'll get into that as we dig further into the final completion of the evaluation. And again, mixed results as it resulted in inpatient costs. On the next slide, you'll see that as well. So encouraging among emergency department visits, still sort of much to be understood about inpatient on the inpatient side. The numbers are obviously smaller here, and we'll take a look at the underlying population in a little bit more detail. So with that, I'm going to pass it to you, Marcy, I believe, to go over additional outcomes.
Yes, thank you. So just overall, I think you can glean from so far the presentation that we broadened the scope of this project. We wanted to achieve sort of a full program to support the high quality care of our patients with sickle cell disease. So we have some additional outcomes that we are measuring internally. So that sickle cell disease navigator in EPIC that I described earlier is now routinely used for documentation by the pediatric hematologist across the enterprise, across the corporation, including the transition assessment and support tool. Our individual pain plans, as of the end of 2023, we haven't yet looked at 2024. About 36% of patients age 0 through 21 had an individual pain plan in Epic, so more than a third. We're expecting that it's going to be higher by now. Our transition of care readiness assessment, again, we're collecting data on that, but it's now routinely used by our hematologists and frequently used by our primary care providers. Community health workers, as described before, have been integrated into the clinical team. It's really in not just in sickle cell disease, but in all of our primary care and care of chronic disease. We have found community health workers to be an essential part of the team. Just to give you one quick example, some of our facilities cannot do transcranial Dopplers on children. We just don't have the setup or the expertise. And our community health workers make sure that they arrange for transportation and connection to the services elsewhere within our system and get those patients to the finish line so they get these studies done that may not be available at every one of our facilities. That's just one small example, but just to give you a flavor for the full scope of activities that our community health workers do. And often they are the communication liaison between the patient and the busy medical provider. So again, they join the medical provider in the exam room for the visits oftentimes. So again, it's just a really key part of our care team. And then again, the support groups from our CBOs, our community-based organizations, we've been able to, again, support them with both financial resources and a more robust connection with our facilities. Next, that's Bruce.
Hi, yes, so I'm going to just briefly speak about some of the challenges and lessons from the grant. Once again, this was a large multi-year grant. It turned out to be a 4-year grant in a large health network. So it might not be, some of these things might be specific to those conditions. But some of the challenges, well, H&H was a center of COVID, especially during the early, most brutal phases of the epidemic. So those were, I think we all know, we all had challenges with COVID and all of the all healthcare providers. As a government agency, we did have a protracted hiring process that posed a little bit of a challenge, especially with community health workers and other, well, especially with regarding our community health workers and other grant personnel. As you saw in some of the charts, provider engagement was a problem, or was an issue. Let's put it that way. The provider engagement was not uniform. Was not it varied. It had a very broad variance among the different provider types. For example, the peds hematologists, who were easy to reach, had very high engagement. I think there was only one peds hematologist in the system who didn't engage. Among the ED personnel, it was much harder. But we had to have an organizational process to continually reach out in many different ways to the providers to get them engaged and to keep them engaged. And I think that once they saw the financial incentives kicking in, I think that probably helped. Next slide, please. So I'll just highlight here the development of the financial incentive payment model posed a number of difficulties. It was very complex because of the 3 provider types and the 8 or we have I think 10 different facilities in the 10 different facilities that were active in the program. I think one facility was not in it. So 3 times 10, we had as many as 30 different departments that were involved. And so there was a lot of complexity to developing the both the financial incentive and then the next point, the payment model approval and implementation. Once again, because we're a large government-owned entity, we're basically an agency of the city of New York. Giving incentive payments had a number of steps that proved difficult, and that we had to pay a much higher attention to than we expected. Next slide, please. Some of the lessons that we learned, a lot of them were process lessons. In the very beginning, the construction of the team proved fortuitous. It turned out we had a lot of different skills in the team, and people from the 3 PIs had different experiences, background, and areas of expertise, as well as the support personnel. So that the variety in the team proved very helpful. Our leader, Dr. Pollard, kept us. This turned out to be very, very helpful as well. We met every week. The team met every week. I mean, sometimes we would skip a week or whatnot, but that was rare, and that proved that proved key in terms of developing a consensus within the team. I won't go into the bureaucratic obstacles. I think they more have to do with H&H and the fact that we're a government entity, so I won't go into all of them, but there were bureaucratic obstacles that we didn't expect. And one of them, it was in terms of the incentives, we had a roster of who was eligible for receiving the incentives, and that had to be up. There were many, I don't know if it was 100 physicians or more that were on that roster from the 3 provider types, and that had to be updated every quarter because the incentives were allocated on a quarterly basis, and that was a major area of concern, or a major area of work. Okay, next slide, please. So the lessons sort of the process lessons and the non-clinical lessons, we as Dr. Stein-Albert just stated, we addressed the holistic quality of care issues. We expressly did not limit it to financial incentives, but we developed the education module, we developed the navigator, we included the community health workers and the CBO. So that was really addressing the holistic quality of care. And we all think that was very important. And I think it probably shows in the evaluation. It's important to note that the navigator, the EPIC navigator, was not universally adopted, and thus we had to do chart reviews to get the quality metrics in the entire project. And I've mentioned before the design of the physician incentives as an issue. And thank you. Next slide.
Next slide is about building on this work to take the grant and use it to drive changes within our hospital system. One of the first things you have to realize about New York City is we have lots of hospitals. We have community hospitals and academic medical centers. And when we look at a component of racial inclusivity, New York Health and Hospitals is ranked #1 in New York State. And if you look down this list, you don't see the major academic centers on this list until further down. And a lot of disparities can be assigned to where patients get their care. There's an unequal, patients choose different hospitals based on place and trust. And that's a key component here. Next slide. So one of the things that we hear in the community is that minorities are unwilling to participate in clinical trials. This is an example of where place and trust come in. When we looked at our internal data on participation in clinical trials for sickle cell disease, the rate of participation was the same as any center within the nation. Next slide. When you look at participation in clinical trials through a racial inclusivity lens, there's a significant difference of where those trials are offered. In racially inclusive hospitals, there are much lower levels of availability of opportunities to participate in clinical trials. Next slide. Another component of where we use the grant to drive change is in the stigma of sickle cell disease. When a patient comes to the ED, they're stigmatized. Many patients will talk about their dignity or their life in making that decision to come into the ED. We know there are interventions that can impact on this stigma. There's small videos, there are analyzing charts, there are ways we can improve providers' attitudes toward sickle cell disease patients in pain. And we created an educational module, which we call Sickling is Not Seeking, and we started implementing that in all our EDs with the help of CBOs and with the help of New York City Department of Health. We put out a health advisory on the importance of stigma in sickle cell disease. Next slide. And finally, we used it to identify, we used the grant to help us drive changes across the system. There's a major gap across the nation, but also within our system between pediatric and adult care. We have 6 pediatric centers. We only had 2 adult centers. There's a difference in how many patients have primary care providers in the pediatric world versus the adult world. When we look at care in the adult world, it's more fragmented. There are higher ED visits, there are higher readmissions. Next slide. Driving force of this grant and the concept of health equity to actually create adult sickle cell programs in each borough. And these programs are going to have this, the ideal components. There'll be a full-time nurse practitioner, there'll be a licensed clinical social worker, there'll be a community health worker added to these adult centers so that we can provide comprehensive care across the lifespan. And next slide.
Okay, I think we've come to the conclusion of our program. I just wanted to say thank you to OMH for giving us the opportunity and thank our team, both our team at Queens and Health and Hospital, as well as our partners in New York State Department of Health and CBOs that we deal with, as well as the New York City Health and Hospital Equity Council. In addition, I'd like to say thank you to Dr. Sanjeev Shah, our managed care partners, as well as Dr. Doug Fish in the State Medicaid Office for all his support and all his contribution to our program and to the help that they provided us. As it says, it takes, generally said, next slide, it takes a village, but in this case, it takes a whole state as well as folks in DC and elsewhere to help us accomplish this. And we thank you very much for the opportunity to do this project. Thank you very much. Finished.
Thank you so much, New York City Health and Hospitals team. This was a great presentation. So we're at the Q&A spot and we're like 16 minutes from the finish line. So I want to start with some of the questions that came in through the chat because they were relevant. One of the questions that came up was, why do you think navigators were not universally used with prescribing hydroxyurea?
So just would want to clarify what we mean by navigator. So the navigator that we talked about, that I spoke about in our electronic health record, that's a term used by Epic, by our electronic health record proprietary, that is sort of putting together a suite of tools for a particular disease or condition. We think of that as a documentation and decision support navigator. The other navigators we think about are our community health workers and our social workers who help our patients navigate the system and connect with the community-based organization. So I'm not sure what this question is referencing. Okay, the Epic-based, thank you. So that's a good question. The out-of-the-box version of our Epic electronic health record had some very basic documentation tools, but really it was not built up and built out in a manner that it really supported the high quality care that was our goal. And so it took nearly a year for us to work with our internal group of builders and also connecting a little bit with Epic National of how to, again, build out tools. And we built it, and then we refined it, and then we tried it, and then we refined it some more. You know, again, as an example of, again, a disease that affects maybe a small proportion of our patients, it was, again, a discussion about putting resources towards doing something to address this patient population. And again, anyone who works in a health system and uses an electronic record knows that they all have build priorities and resources for those builds. So this grant was one of the vehicles that we used to drive that process. And we are going to be presenting these tools to Epic National and see if these can be adapted or adopted for the full Epic package.
If I may add, in general, when any documentation module is presented, you can either present it as a have to do it or not have to do it, and there are pros and cons against both. You don't want a hard stop because it takes a little while for adoption of any new devices that comes to the electronic health record, and over time the use increases as people become more familiar with it, and it's more, and then you have word of mouth that it really helps you document. So it takes a little while to ramp up. It's not everything is adopted right away, especially if there is no force function that stop or you can do your work if you force it. So that's the navigation and the time it takes to build up those.
Right, and to Dr. Poulard's point, clinical providers are creatures of habit, and we get into one routine and then you present them with a potentially new routine. It takes a while for that to be part of their workflow.
And since we were on the topic of the Epic registry, there was a question about whether or not the Epic registry and navigator metrics and indicators were something that could be shared. And also if the learning module was available to anyone outside of the providers that you work with through the New York City Health and Hospital System.
I'll take that. The answer is we're happy to share.
You're on mute, Ken.
All right, I pressed the wrong button. So, excuse me. We're happy to share. And we also gave it to the community-based organizations as a tool to discuss hydroxyurea use. So it's open to everyone, and we're happy to share.
Great, thank you. So let's talk about treatment and approaches and access to those. How are community health workers being incorporated to healthcare teams focused on patients living with sickle cell disease?
We want them to be the standard part of a sickle cell clinic. You see the hematologist, the community health worker is readily available. One of the things that is going to be highlighted in the outcomes of this grant is how to pay for that community health worker. And that's going to be a result that needs to be addressed with CMS.
New York State, in fact, has seen the value of community health workers for maternal child health care, as well as chronic disease. And recently in early 2024, implemented a model which is just being now ramped up in terms of building an infrastructure for the model, but considering work units for community health workers and reimbursement around those work units, as long as they meet particular criteria. So I think there's a lot of evidence around community health workers supporting quality care for, again, maternal child health, but chronic diseases as well. And I think over time, that's going to be a model that's going to be adopted across the country. But in New York State, they already are moving forward with that in terms of reimbursement.
Thank you. So another question that came in both through the chat as well as through the registration link is what is being done to make medication such as hydroxyurea accessible to low-income patients?
Hydroxyurea is off patent. It is a relatively inexpensive drug, and I think it's on Medicaid formularies across the country.
Great, thank you so much. So let's talk about a little bit about the medication and treatment efficacy. How can CBOs encourage more use of hydroxyurea in patients living with sickle cell disease?
To me, the answer is to be that help with the decision support for patients. They need to hear from trusted sources that hydroxyurea makes a difference, and community-based organizations make that difference.
They get in the community-based in the support group. They also have people that are on hydroxyurea that are attending it and also can talk about it because they have firsthand experience that they share with those that are considering it. And both the community organization and the community health worker work together on those, making sure that those patients are there and get the support that they need and get the encouragement, and knowing that it's not that hard to manage those patients and provide them the support that they need.
And also to make sure that those folks who are running the community-based organizations have the best possible, the latest knowledge on treatment management and so forth. And I think a lot of our relationships with these CBOs, in that we made it a priority to share with them our educational module and what we were doing so that they could in turn share with the community.
In addition, we do attend some of their meetings. So the physicians also as expert, subject matter expert, to go to some of these community board meetings, and they ask questions, lots of questions, and they can be there, for hours listening to them and asking questions. So it's been part of being part of the village.
Great. So the next question is kind of twofold because people want to know how providers or support people from the community can help. So specifically, the question was about training for emergency room providers, as well as any school teachers, counselors, nurses. Is there a way that you can briefly describe how trainings can better improve to screen for pain crisis and what to do in those situations?
We need to, with partnership for community-based organizations, reach out to schools. There are guidelines for teachers about sickle cell disease, and teachers need to know about it. We also need to reach out to the EDs to continuously talk about the stigma of sickle cell disease, that these patients need to be believed, and that they're coming to the ED for their assistance to go back to their real lives, which isn't the ED.
So during your presentation, you talked about the prevalence of sickle cell disease in Blacks and African Americans. There's a question about how prevalent it is within the Hispanic community as well.
It's about 1 in 16,000 births. The Hispanic community makes up about 10% of the sickle cell population in the United States. You find in the Americas, you find sickle cell disease following the slave trade. So you will find it, track it along wherever the slave trade was. In the rest of the world, you track it by where malaria falciparens was there. It is 90% protective against death from malaria falciparens. So you're going to see it in sub-Saharan Africa. You're going to see it in the Middle East. You're going to see it in India, and you're going to see it in the Mediterranean countries.
Right. So we have about 4 minutes. And I want to take the opportunity to let you all kind of ponder for a moment. If there were 3 important factors that you want to leave us with, and I know it's going to be a fight, who's going to get to the mic first, but 3 important factors that you want OMH and our listening crew know about sickle cell, the use of hydroxyurea, or the impact of the work that you have done within New York City. Not all at once.
Okay.
I'm sorry, Bernie. To me, it's priority. We have to keep sickle cell disease as a high priority thing. We need groups like OMH to be that driving force for change. It's a rare disease. It's a high cost disease, but it's small on the scale of what CMS pays for, what New York State Medicaid deals with, what hospital systems deal with. We need it constantly on that priority. We need someone to say this is an important thing and this is what needs to be done.
For number 2, if I may, and let's give our care teams the tools they need to reach those goals. Sometimes it's as simple as, again, creating an infrastructure for documentation and decision support, allowing their care teams to not just be the physician and the nurse, but recognizing that there are other folks who make a difference and supporting those clinicians that way. So again, a recognition that these patients need extra time and extra resources. And let's support our clinical care teams again, and give them the education and the tools necessary to deliver that high quality care.
Okay. As far as I'm concerned, I think, partnership with the community-based organization also, help us. And we also have to remember that the equity question goes in terms of community-based organization. The better organized communities have better community-based support. And our community-based organization working in that field suffer from the same inequities that our patients suffer from. And they need lots of help into building them up so that they can support the patient as well as other well-off communities can do.
All right, I'm going to open the mic just one last time. Is there any other? I know Bruce, do you have anything you want to add before we close out?
I'd like to see OMH continue to work with the Medicaid offices at every state on the issue of sustainability, and I'll support what the 3 PIs said. The community, finding ways that the community health workers and other ancillary personnel can be funded. They were not funded they were not eligible in this grant for the same incentives. But working, we have to develop the issue of sustainability, and that's going to be a partnership between between the federal government and the state Medicaid offices.
Well, thank you. I think it has been well heard that sickle cell disease needs to be a high priority. And we need to develop and disseminate, excuse me, tools for care teams to be able to be better providers, as well as partnerships are huge. If that's local partnerships, state partnerships, federal partnerships, we all need to be making sickle cell disease a high priority. I thank you all for joining us today, as well as I thank our presenters for providing such in-depth information. Your contact information for the presenters should be available as well, and we will ensure that the slides as well as the presentation, which has been recorded, the link will be available to you. I thank you again and have a great day.
Thank you.
Thank you.